62-year-old female, graduated, a BA graduate, homemaker by occupation, resident of Jharkhand, belongs to upper middle class according to modified Kuppuswamy scale, informant being husband and son with good reliability. Came with chief complaints of generalized itching for the past 45 days, yellowish discoloration of eyes and urine since 20 days, and abdominal pain since 10 days.
Okay.
History of presenting illness. She was apparently all right till 45 days back when she developed itching, which is insidious in onset, initially in the legs, intermittent, and only during daytime, which gradually progressed to involve entire body and has become continuous, affecting her sleep. It is associated with bleeding from the skin while scratching, and the severity being increased from grade 1 to grade 4. And then followed by she developed yellowish discoloration of eyes for the past 20 days, which was initially noted by her family member, which is insidious in onset, gradually progressed to involve entire body, and associated with yellowish urine, which is not associated with pale stools. Followed by pain in the right upper abdomen since 10 days, which is insidious onset, dull aching, continuous, non-radiating, with severity of 4, VAS 4, aggravated on lying down on the right side. History of loss of appetite since 1 month in such a way she has reduced her food intake to less than 50% of her routine. No history of lump, fever, chills, loss of weight. No history of abdominal distension. No history of blood vomiting, black colored stools, silvery stools. No history of prodrome in the form of rash, joint pains, body pains, nausea, vomiting. No history of blood transfusion, tattooing, high risk behavior. No history of endoscopic intervention or surgery. Past history, she's a known case of hypertensive on amlodipine 5 mg OD. No history of diabetes, hypothyroidism, or TB. Treatment history, history of CAM intake in the form of Ayurvedic medicine, live 52, for 1 week after the onset of jaundice. And since there was no improvement, she consulted local physician who did few blood tests and ultrasound abdomen and advised for admission. Personal history, she consumes only vegetarian foods, no addictions, bladder and bowel habits are regular. Family history is non-contributory. Dietary recall, she's currently taking only 1000 calories with deficit of 600 and protein of 30 gram with deficit of 30 gram. Summary, 62-year-old female, hypertensive, presented with pruritus for past 45 days, progressive cholestatic jaundice since 20 days, followed by right upper abdominal pain since 10 days. Following which she took CAM for 1 week, associated with loss of appetite with no loss of weight or prodromal symptoms.
So a reasonably good account. It was good description of the initial symptom of pruritus. So you uh, clearly described the onset, progression, severity, virtually everything. But the same didn't seem to be happening in case of jaundice. Like jaundice, you said very clearly that it was detected by the family member. That is important. As we discuss the differential diagnosis, we will come to that. But subsequently, like here, you are saying progressive cholestatic jaundice, but this description didn't came very clearly that what happened after the initial detection of jaundice. What were the events, and then certain points they see gradually progress to involve entire body. It requires to be a little more elaborated little more. Okay.
Okay, sir.
So and associated symptoms which help you in differential diagnosis, that should be emphasized. And you can go to the
Sir.
pain you described under 6 headings. So most of the time we describe pain under
14.
many more headings. Okay, so most of the points, relevant points you have covered. Severity you have covered 4/10, dalacking, continuous, and right upper quadrant you have said. But aggravating on lying down on the right side. Okay, there are few more points will come into pain. So you should always be ready with that. Okay, I'm going to describe pain in that many headings, and jaundice is also virtually mathematical description. The way you describe pain you will describe 10 days, then you see you this is a still image.
So,
Preeti, we have lost your video. So this is an still image. So when you are presenting a history, we always expect that it should be in the form of a running video rather than a still image. So one point of description you have given 10 days, but what is happening to pain over 10 days, that we don't have clear idea. Okay, the same happened in the jaundice. Jaundice you always described. It was very. I was impressed that you said that okay, this was detected by the family member. Uh, but obviously, anything which is happening prior to that becomes prodrome. Okay, so prodrome by definition is what? Prodrome is symptoms which are occurring before detection of jaundice.
jaundice.
Patient jaundice gets detected. So here we will say that pruritus can be a prodrome. Prodrome can be fever, anorexia, nausea, vomiting. So the points which help you in distinguishing, that should be highlighted by in the negative history, or if it is not present or it present in a equivocal manner, that should be decided. That should be described. That we will come with those points as we go along the discussion. Okay, so what are the consideration here? You analyze this history. How do you analyze this one? How do you analyze pain, jaundice, and pruritus?
So, since pruritus has started early, sir, but there is no long gap between jaundice and pruritus, I will, along with abdominal pain, I'll consider it could be extra hepatic cholestatic jaundice, sir.
So generally, when we talk of EHBO, we go back a one step earlier. Okay, so it can be cholestasis, which can be intrahepatic cholestasis or it can be extrahepatic cholestasis. Okay, so you should have said that patient has presented with
Pruritus,
cholestasis.
cholestasis. Yes, sir.
Cholestasis, and I suspect that this is because of extrahepatic biliary obstruction. So cholestasis will take two forms. One is intrahepatic cholestasis, extrahepatic. So my question is, on what points we make a distinction between intrahepatic cholestasis and extrahepatic cholestasis?
Okay, sir. Intrahepatic cholestasis will have long duration of pruritus, history of drug
Acha,
prodrome, or
Preeti,
sir,
how long is long?
year,
Because in medicine we always need to define it first of all, and second, in the same breath, you must have seen lots of cases of viral hepatitis, and some of those must be in viral hepatitis in cholestatic phase. So how long history we get? Here we have how many days of gap?
here pruritus followed by jaundice, sir.
How many? What was the gap? How many days?
Here only
25 days.
15 days, sir.
15 days. So 35 days you, or 45 days
45
pruritus.
days is pruritus.
45 days na, so 25 days gap.
Oh, sorry, sir. Huh.
हाँ, सो 25 डॉक्टर्स की मैथ खराब होती है, इतनी खराब नहीं होती है. ठीक है. So 25 days gap. So
Okay, sir.
25 days gap is good enough for intrahepatic pruritus. So long gap, or whatever, long or short gap, that doesn't make practically distinction between intrahepatic and extrahepatic pruritus. So what makes the distinction?
Or jaundice, initially it was noted by her family member. Maybe jaundice might have also started during the time of pruritus, which she might have missed.
You are losing the sight. Intrahepatic cholestasis we are considering, that is overridingly, most cases will be because of viral hepatitis. Okay, so how does the patient of viral hepatitis comes to you?
Viral hepatitis, initially they'll have 40 to 60% will have prodrome, sir. Uh, 40% may not have prodrome also. Then fever initially, then it will subside and followed by jaundice, fever,
So
joint pains or body pains, rash.
the most important symptom you are forgetting, whenever there is intrahepatic event, there will be always anorexia, nausea, loss of appetite, loss of sense of well-being. Those things will start happening. So patient notices first that he is not feeling well. He's feeling anorexic, occasionally nausea, maybe even vomiting. There will be lack of energy, and he knows he is not well. That is the typically when you see viral hepatitis patient, that is what it happens. So meaning thereby that systemic symptoms are dominating, and what will happen that he will also notice there is high colored urine. So you said yellowish urine because urine normally is yellow colored, so seeing yellowish is doesn't give the proper message. So we always promote to say that high colored urine. High colored matlab it is still yellow, but it is more than yellow. So that is the typical description is given. But the systemic symptoms are very important. So how the jaundice was detected? So that jaundice will not be detected by the family members or friends or people or the colleagues. It will be detected first by the patient only, because there is so much symptom going on: anorexia, nausea, loss of energy, lack of sense of well-being. ठीक है? So that makes a distinction between intrahepatic. And if it progresses far down, then other symptoms will start coming in.
Okay, sir.
That okay, hepatic encephalopathy, coagulopathy, those things, but those are little far. Only if patient develops liver failure, encephalopathy. So those things. The second point is also which you made very clearly that you should have utilized, that with intrahepatic cholestasis, most of the time fever tends to subside as the icteric phase starts. So in intrahepatic jaundice, fever is a manifestation, but it is a manifestation in pre-icteric phase. You understand what I'm saying?
Yes, sir.
Only certain forms of intrahepatic cholestasis, like malaria, uh, like typhoid fever, the fever will tend to persist, CMV virus. So, but most of the typical जो A to E virus होती है, उसमें the jaundice starts and the fever subsides. Whereas what happens in extrahepatic biliary obstruction?
Fever starts later. Fever will continue and it may start later on.
Either fever will not occur, because extrahepatic biliary obstruction only a small subset will have what we describe as cholangitis. ठीक है? Cholangitis will be manifestation in a smaller percentage of the patient. So definitely less than 50%, most of the time less than one third of the patients. And this fever will tend to persist through the jaundice. ठीक है? It will not subside with the appearance of jaundice. So that will make distinction. Okay, so that is very important. And does clay colored stool makes a difference in differential diagnosis?
Obstruction, it can. Tells me.
It can happen in both intrahepatic as well as extrahepatic. So clay colored stool will not make a distinction. But say for if patient gives you history of melena, then
Ampullary carcinoma, I'll think also.
ampullary carcinoma, it can go particularly more so if it is associated with decrease in jaundice during that episode or decrease in pruritus. So fluctuation, what you say fluctuation, patient will not describe you fluctuation. Patient will describe fluctuation of pruritus. So patient may not be able to appreciate fluctuation of jaundice. Preeti, we lost your video.
Yeah.
So how do you take history of fluctuation?
Uh, pruritus has told.
Hello, how do you take
Because
history of
yellowish discoloration,
fluctuation?
she initially noted her yellowish discoloration on eyes in eyes, sir, and then body maybe the same way it will be decreasing at least tinge
There are
yellowish tinge, and yellowish urine, your high colored urine might be.
that is the catch, Preeti. That decrease in yellowness is difficult to appreciate first, and because the bilirubin deposited in elastic tissue is known to persist even after serum bilirubin improves,
Yes, sir.
so that will not be reflected very clearly. So for the fluctuation of jaundice, we rely heavily on the fluctuation in intensity of pruritus, fluctuation in clay colored stool if the patient has symptom. So if that improves, that gives you clear cut clue. And if it is associated with, say, for melanic or melanic stool bleed during that period, so that becomes that will also help you in differential diagnosis. But fluctuation, we hardly ever go by yellowness. Most of the time we go by change in intensity of pruritus. And when fluctuation is present, this is present over hours, days, or weeks. What over what period we are expecting fluctuation to occur?
Ampullary, it should be day days.
Mostly it will be over weeks. So normally we don't try to look for fluctuation if the history is for just for 3 weeks. Like this patient has only 20 days history of jaundice. So this is not exactly the best time to look for fluctuation, because fluctuation, for fluctuation, you need to have at least two distinct peaks. Na? So one fall and then again picking, so at least that much, so that will happen over a period of weeks. So unless history is genuinely long, several weeks period, so that over that period fluctuation now. So you should realize that this is not hemolysis, that okay, 6 hours of hemolysis and it goes and jaundice start decreasing. So it is not like, it doesn't work like that. Okay.
Okay, sir.
So that is how you will make a distinction between extrahepatic. So you should have started interpretation in that way, that yellow discoloration. And whenever there is yellow discoloration, we make in the presentation part, we always try to make a distinction. Whenever we present a case of jaundice, we always try to make whether this is hemolysis or conjugated. So how do you make a distinction?
Yellowish urine is not seen in unconjugated hyperbilirubinemia, sir.
So
Hemolysis.
that is what na associated with yellow urine you are saying. So that's why I said the high colored urine,
Okay.
and high colored urine is persistent. So this is not one time. One time high colored urine will be depend on the fluid intake. It may be present.
Okay, sir.
So basically, step one in case of jaundice will be whether this is choleric or non-choleric, acholeric. So choleric jaundice or acholeric jaundice. Acholeric jaundice will be basically hemolysis,
Hemolysis.
or choleric will be all cholestatic causes which we are discussing, intra and extrahepatic. So when we go to extrahepatic, then we try to make a distinction between benign and malignant etiology. So how do you make distinction between benign and malignant?
Short duration or very long duration favors benign etiology,
Which
sir.
one? Very long duration
Very
favors
long
benign.
or short? Very short. Short history also.
Very short will make benign.
Very short or very too long.
अगर अगर पेशेंट को पेरियम्पलरी कार्सिनोमा है, आपको 10 दिन में आ गया, तो आप उसको बोलोगे कि बेनाइन है. It is the patient threshold, na? So generally the patient can come to any time. So talk of something more concrete.
Okay, sir. Yeah, older age with history of severe anorexia, weight loss, uh, severe abdominal
Severe
those
abdominal.
pain. Weight gain.
Leading cause of extrahepatic biliary obstruction, what do you see at your center? You must have seen lots of cases of ESBO.
Choledocholitis.
कोलोडोकोलिथियसिस पेन होती है?
Yes, sir.
हाँ, कितने
Yes, sir.
परसेंटेज में पेन होती है? Virtually 95% plus. Almost everybody who has got choledocholitis will have pain. So meaning thereby that if you pain you can use as a qualitative variable and you can use as a more elaborate matter as a quantitative variable. ठीक है? So you simply pain if you are talking about, then possibly benign will have almost uh, maybe more common in benign compared to malignant. Because in malignant, you know, at least 50% of malignancy will not have pain. ठीक है?
Yes,
So benign अगर biliary obstruction में अगर stone disease we talk with 95%, which is the commonest cause, but the strictures may or may not be depending on the situation. What percentage of sclerosing cholangitis will have pain?
sir. Yes. Percentage, I don't know, sir.
You must have read na chapter of PSC,
Yes,
some of the review articles. तो उसमें clinical manifestation की table आती है ना? ठीक है? So उसमें देखा नहीं कि so I
sir.
asked you question on sclerosing cholangitis. I didn't say PSC, but you could have
Yes,
taken analogy there.
8 to 10%, sir.
नहीं, more. That is the catch point. So that's why I asked you question. Okay, so in PSC, there is explanation for that. I will not go at the moment into that. But one third to half of the patient will have pain, but this may not be typical biliary colic. Okay, okay. And how do you identify typical biliary colic? How do you describe?
It is a crescendo.
Episodic,
Episodic pain which gradually increases.
and whenever we say it will be crescendo decrescendo type of pain. Okay, so and what more description?
So it gradually peaks over 15 to 30 minutes and plateaus for at least 1 to 2 hours and gradually decreases.
So why does it peak over 15 to 20 minutes? What is the mechanism of pain in case of biliary colic?
Stone obstruction. Usually after eating meal, gallbladder tries to empty it and pump bile out of this bile duct into duodenum, sir. So
So contraction.
contraction
So which
against obstruction leads to pain.
pain? So which contraction lasts 15 minutes? You must have read, na? MMC, at least in the GIT, you must have read MMC
Yes, sir.
phase 1, 2, 3, 4. That is fasting pattern. So, but even in the fed pattern, you will see cluster contraction. So, no contraction in GIT can last 15-20 minutes, na? Because these are a smooth muscle. These are not the skeletal muscle. Skeletal muscle you can keep tonically contracted as long as you want, but a smooth muscle contraction will not last. So, like ureteric colic comes very sharp, very severe, and within a minute or two, it wanes. It starts decreasing, whether you give anything or not. Okay, but it doesn't happen like that in case of uh, biliary colic. So, ureteric colic and biliary colic are different. Why so?
Basically, usually colic should be used only if it lasts 1 to 2 minutes, sir. Here
So,
it is.
so why doesn't biliary colic last 1 to 2 minutes? It lasts longer.
I don't know, sir.
So what happens that ureter has got very good layer of a smooth muscle. ठीक है? So when you have circular and longitudinal muscle, they are pretty well developed out there. But in case of CBD, the muscle layer is very thin,
Okay, sir.
so it is not so well developed. So it doesn't produce good enough contraction to produce that is strong contraction which will cause pain. So this pain which happens in biliary colic is related more to dilatation or increase in the pressure inside the biliary system, which causes pain. So that's why biliary colic occurs 15-30 minutes and then it wanes. And if it lasts several hours, then what do you suspect?
Cholecystitis, sir. Acute cholecystitis.
So associated complications. ठीक है, so not only cholecystitis, there can be other reasons like cholangitis is settling in, the pain will persist. Okay, cholecystitis sets in, the pain will persist, or stone is impacted, say for in the neck of gallbladder and causing inflammation and penetration there. So then also the pain will persist. ठीक है, like Mirige's type of situation. So then also pain will persist. So there is a list of differential diagnosis if the pain persists. But you are right that in Schlesinger it is written that if pain persists more than 30 to 60 minutes or if several hours, then you should suspect acute cholecystitis because that is the commonest complication which will happen in that situation. And with the GV stone. So what percentage of cholecystolithiasis patients will have CVD stone? ये कॉमन फिगर्स हैं,
5%.
थोड़ा सा बढ़ाओ. So 5 to 10%.
10%. 10%.
So 5 to 10%. And what percentage of CVD stone will have associated GV stone?
80%.
और बढ़ाओ.
98.
95%. ठीक है. So what is if there is no GV stone, then we call it either it can be primary CVD stone or it can be single stone which has slipped out. Okay. And so okay, we will stop on this point. We were at the level of making distinction between extrahepatic benign and malignant obstruction.
Yes, sir.
So we were trying to make a distinction. You made the mention of pain, and then I was not fully agreeing to you that pain signifies malignant obstruction.
Okay, sir.
Okay, so that is not an important point. So what are the important points which make distinction between benign and malignant? One, you said that I agree that okay, if there is significant weight loss or disproportionate weight loss, then malignancy is possibly more likely. Elderly patient malignancy is more likely. So these 2 points you mentioned, and I agree to that. Any more points? You have seen it so many times.
Progressive jaundice.
प्रोग्रेसिव तो दोनों ही होगा. अगर स्ट्रक्चर होगा तो पर भी प्रोग्रेसिव होगा. अगर स्टोन इम्पैक्टेड हो रहा है नीचे लोअर एंड पे, वो भी प्रोग्रेसिव होगा. ठीक है. Deep jaundice generally, what is the average mean level in case of CVD stone?
10 to 15, sir.
10 to 15.
Yes, sir.
प्रीति, क्या हो गया? 10 to
15.
15 milligram percent. It is mentioned in the textbooks that 2 to 6 milligram percent, or somewhere mentioned 4 to 6 milligram percent. The usual patients of CVD stone will have jaundice because typically obstruction in case of stone disease is typically intermittent. So deep jaundice is uncommon. And in stone disease, what are the situation you get deep jaundice?
Stone stricture complex.
One. So there can
Mirisi
be
syndrome.
mirage is very good or
Cholangitis.
very good. Anything, something more common than that? Stone impacted at ampulla.
Ampulla. Yes, sir.
Tend to get impacted. अगर वहाँ impact हो गया, so then the jaundice can be deep. So these are the situation jaundice can be deep. So deep jaundice always goes in favor of malignant obstruction. Then something very commonly you see, particularly people coming from North India, like this patient is coming from Jharkhand, na? So North India, Eastern India coming. So which malignancy is more common?
Carcinoma gallbladder, sir.
Gallbladder. So what are the different presentation of carcinoma gallbladder? One is jaundice, other
Abdominal pain.
okay, or
Abdominal pain. Same thing. Anorexia, weight loss. Biliary colic. Previous history of biliary colic.
लंप के साथ प्रेजेंट करते नहीं देखा आज तक हैं? Lump
Eh,
awareness of lump. Okay, if patient comes with history of jaundice and gives you history that okay, I'm able to feel lump in right upper quadrant or whatever area, ठीक है? So then malignancy becomes much more likely. So carcinoma gallbladder, because patient will, because of symptoms, it will ultimately end up palpating or because of pain. So he will say यहाँ पे गांठ बनी हुई है. ठीक है, that can be liver metastasis, that can be palpable GB, hard palpable GB. So in whatever form, even in lower CVD block, if the patient is cystic gallbladder and if patient is able to make out that there is a lump, so lump goes in favor of. So we have made out that if there is disproportionate weight loss, significant weight loss, if there is elderly patient, if there is deep jaundice and there is awareness of pain and fever which is persisting into ecteric phase. So these are the 5 6 points which we made. We will make a distinction between benign and malignant obstruction. Okay, so here you are considering what? You are considering benign or malignant?
Here I'm considering malignant, sir. Considering her age and short, okay, progress, deep jaundice.
How much is she has lost weight? How much?
Only point going against it is weight loss, sir. There is no loss of weight.
There is no loss of weight. So has she measured? That is important thing. That's in because when you are taking such history, it is very important because your patient is from Jharkhand
Yes, sir.
and she is from the low middle socioeconomic class.
Yes, sir.
So in the history taking, you should have asked straightforward. I know that Hutchison says that leading point direct questioning should not be done, but at the DM level, you should ask directly, do you know your pre-morbid weight? If the patient doesn't know pre-morbid weight and if patient doesn't know current weight, then you will not give credence to that. Then you will go to indirect markers. ओके, कि घर में किसी ने बोला कि आप दुबले हो गए हो, वजन कम हो गया है, कमजोर दिख रहे हो, ठीक है? सो दोज थिंग्स, क्लोथ्स हैव लूजेंड, हालांकि वहां पे तो मोस्टली दे वियर क्लोथ्स विथ लूजनिंग, उसमें अगर सारी सारी वियरिंग लेडी है, शी मे नॉट कंप्लेन यू, बट स्टिल सम ऑफ द इंटेलिजेंट लेडीज विल कंप्लेन यू कि ब्लाउज थोड़ा ढीला हो गया है, ठीक है? But some indirect sign when we go into examination part, then we will able to make out whether there is significant weight loss. Okay,
Okay, sir.
so it is important कि नहीं, there is no significant weight loss or the history is not coming forward, so you need to make a distinction. You
Yes, sir.
understand the point?
Yes, sir.
So if patient is not able to say, that doesn't mean that there is no significant weight loss. Okay,
Okay,
so
sir.
you want to consider malignant biliary obstruction. Which one first?
Since she is from Ganges belt, I would consider carcinoma gallbladder as the first DD, sir.
Okay, the only so
Yeah.
straightforward, you will go to demography.
Um,
The rule of thumb is what? Na? Rule of thumb is if the patient symptom is suggesting something, so then that should be taken in, should be given credit. Okay, and if that is going equivocal, then we will use the prevalence of the disease to make a distinction between the two. You understand what point I'm making?
yes.
So the rule of thumb says what? That two malignancies are generally painless and two is generally painful. Okay. So what are the two malignancies which are painless? We are talking of EHBO, malignant EHBO.
Periampullary carcinoma and cholangiocarcinoma are
So
usually.
these two are painless. So this is because painful situation. So you will say, I'm considering because the patient is having pain. So that's why I'm considering carcinoma gallbladder or carcinoma pancreas. और कार्सिनोमा गॉल ब्लैडर और पेंक्रियास के पेन में क्या डिफरेंस होती है?
Pancreatic pain usually seen in the epigastric region, which is dull, deep, dull, boring, and radiating to back, sir.
Radiating to back. So that is typical, but typical pancreatic pain will occur only in one third of the patients, and rest will not have. So that also will be visceral pain. But important that at presentation, at the first presentation, the only one third of the patients of pancreatic carcinoma will have significant pain. But if you talk of the natural history in the course of the disease, then 80-90% will become painful. So you understand the difference.
Yes, sir. Yes, sir.
That at presentation, majority of carcinoma pancreas will be painless. So 30% बोला ना, so meaning thereby कि 70% में pain नहीं है, ठीक है? The figure reverses in case of carcinoma gallbladder. So almost 80% will have pain at presentation. ठीक है? तो रूल ऑफ थंब कि जब एक्स्ट्रा हेपेटिक मैलिग्नेंट ऑब्स्ट्रक्शन सस्पेक्ट कर रहे हैं, अगर पेन है तो फर्स्ट प्रोबेबिलिटी विल बी कार्सिनोमा गॉल ब्लैडर. यू अंडरस्टैंड?
Yes,
ठीक है, अनलेस यू आर कंसिडरिंग वेरी वेरी एडवांस डिजीज. ओके, एंड इसमें एडेड फीचर है कि वो गैंगेटिक बेल्ट से है, हाई प्रेवलेंस जोन से है, ठीक है, रिलेटिवली विच अकर्स अर्ली, कार्सिनोमा पेंक्रियाज एंड कार्सिनोमा गॉल ब्लैडर age wise, which is occurs early?
gallbladder, sir.
Gall bladder. So typically जो carcinoma pancreas, there will be aberrant things, but typical age is later compared to carcinoma gallbladder. So that will be the additional reason here for considering carcinoma gallbladder. Okay. uh, Anything else? Are you aware of any series from India? There are multiple series available on so-called surgical obstructive jaundice or extrahepatic biliary obstruction. What is the frequency of these tumors causing
Yes,
obstructive
sir.
jaundice?
SGPGI series, I'll
Hmm.
go for that. So carcinoma gallbladder is 58%, and carcinoma head of pancreas is 36%. Then followed by periampullary 18% and cholangiocarcinoma at 10%, sir. 11%.
Any other series? थोड़ा ओल्डर है, बट एम से भी एक इम्पोर्टेंट सीरीज है ना,
Rupesh Sharma.
600 प्लस. हाँ, एमपी शर्मा,
Yes, sir.
डॉक्टर एमपी शर्मा का एक सीरीज है, ठीक है, उसमें है और मल्टीपल सीरीज हैं. सो बेसिक इज दैट व्हेन यू आर गोइंग फॉर एग्जाम, you should keep at least 3-4 series in hand, so that you know that which is the commonest series. So that will be because you want to make an additional point na, this you are dragging at earlier stage. So at a lower point you will mention that okay, carcinoma gallbladder remains the commonest cause for malignant extrahepatic biliary obstruction in North India. ओके, सो उसमें बोलेंगे कि डॉक्टर एमपी शर्मा सीरीज में भी कॉमनेस था, संजय गांधी की सीरीज में भी कॉमनेस था, XYZ सीरीज में भी कॉमनेस था. सो दैट विल बिकम will strengthen your argument and will also show that you are aware of the literature which is available. Okay.
Okay.
So first possibility carcinoma gallbladder. Any second, third, fourth possibility, or we open and set case of carcinoma gallbladder?
It could be my second read is carcinoma head of pancreas, sir. Still, I cannot rule it out completely. Uh,
Hmm. But but you will still want to keep cholangiocarcinoma, periampullary carcinoma.
since 30%, one third patients will present with painful progressive cholestatic jaundice, I have considered
Hmm.
Those also as my DDs, but lower down the order, sir.
Cholangiocarcinoma.
Since she developed pruritus first, so I will consider cholangiocarcinoma also, sir.
So why should cholangiocarcinoma develop pruritus first? That will cause biliary obstruction. We are talking of extrahepatic biliary obstruction. Na? We are not talking of intrahepatic cholangiocarcinoma. We are talking of extrahepatic obstruction caused by cholangiocarcinoma. So it will cause jaundice upfront. For periampullary carcinoma, I do understand because that involves duodenal carcinoma, that involves ampullary carcinoma, and those things. By the way, what is the definition of periampullary carcinoma?
Um, within 2 centimeters of structures within 2 centimeters of ampulla comes under periampullary.
Okay, very good. So it will involve what tumors?
Ampulla, distal
Hmm.
distal CBD,
Hmm.
CAHOP, and
Hmm.
duodenum.
Duodenum. So very important. So this will include. And so cholangiocarcinoma will be extremely difficult. So and rather when you are keeping benign, only why only miriges? Why not stone impacted at ampulla?
Severe stone impacted at ampulla. She like that. Okay. Severe
That
pain. She's having moderate intensity of pain.
that doesn't distinguishes, man. That doesn't that mirigi is not a common situation. Stone impaction at ampulla is much more common than miriges. So you will rather than it is when
Pancreas.
you go for presentation, na, it is just play of words and precision of language that matters a lot.
Okay,
So
sir.
you should have taken that complicated gallstone disease.
Okay, sir.
So in the heading of complicated is gallstone disease, you could have kept mirages, you could have a stone impacted,
Okay.
or even complicated cholecystitis sometimes, and even for that matter, xanthogrammatis cholecystitis. Also, everything can be covered. How common, how serious you are with about SCC in this patient? With lymph node compression of extrahepatic biliary tree, you are so precise that first of all you want to consider HCC. So first question is how commonly HCC presents with jaundice, and second question how commonly HCC causes extrahepatic biliary obstruction.
5% will
5% causes obstruction or 5% with jaundice.
5% will cause cholestatic jaundice, sir.
By
I
causing
think
extrahepatic biliary obstruction, that figures are high. ठीक है? I think this figure is not correct. So even presentation with jaundice in HCC is uncommon.
yes, sir.
ठीक है? So only 10 to 20% or some series going up to 30% will present with jaundice, but biliary not because of biliary obstruction, by the other mechanism, because it has other reasons. It can have other reasons for jaundice. So you didn't gain anything out of keeping extrahepatic biliary compression of biliary tree. So it should have been rephrased simply that hepatocellular carcinoma. Okay, you don't gain any brownie point. नंबर बढ़ाने के लिए तो यहाँ कोई जगह थी नहीं. ठीक है, सो उसको नंबर 5 पे रखा हुआ था ना आपने, तो नंबर 5 पे रहने देना था. और जब एससीसी आ ही गया है तो विल यू लाइक टू कंसीडर nodal NHL?
Okay. No.
So you will say on history it is difficult to keep. I will like to examine the patient and then. So what I'm telling you is the how to wriggle out. So you are stuck in a scenario. So beforehand, when you are preparing for exam, at that time only you make your strategy that if I'm stuck somewhere, then how will you wriggle out? ठीक है. So this is how you wriggle out in different situations. Somewhere you will say कि okay sir I have read but I'm not able to recall at the moment. That will save your dignity, and then you wriggle out also. Here you can say कि sir I will like to examine and then I will like to make up my mind. ठीक है. So that beforehand as you go for examination ना, how to wriggle out from a impacted situation where you get stuck on some point, so that you should be ready. Okay, so go for examination.
General examination, she is conscious, coherent, cooperative, comfortably lying on bed with pulse rate of 85 per minute, normal volume, blood pressure of 130/80 mmHg in right arm supine position, saturation of 100% under room air, with BMI of 36 and mid-arm circumference of 24 centimeter.
Weight कितना है patient का?
Weight is 73, sir.
And height?
143 centimeter.
So she is morbidly obese.
Yes, sir.
Okay, okay, fine, go ahead.
Icterus, icterus present, sir. Vitiligo is present all over. Vitiligo all over the body with scratch marks with excoriation and blood spots noted. No lymphadenopathy, clubbing, and pedal edema. No external markers of malignancy. Abdominal examination on inspection. Flat, flanks are not full. Umbilicus is in midline, center, inverted. All quadrants are moving equally with respiration. No visible veins, scars, sinuses, and pulsations. Hernial orifices are free. On palpation, superficial palpation, there is no warmth or tenderness. Deep palpation, liver is tender, palpable 5 centimeter below right coastal margin in mid clavicular line with smooth surface, sharp border, and firm consistency. And there is globular, firm, tender mass of size 4 into 3 centimeter felt in the right hypochondrium, moving with respiration, with medial, lateral, and inferior margins felt, with superior margin continuous with the liver, with no intrinsic mobility. And spleen is not palpable, sir. On percussion, liver span is 14 centimeter in mid-clavicular line. Drop space is tympanic. Auscultation, there is no bruit. Bowel sounds are heard. Per rectal examination, fingers stained with yellow stools, and there are no deposits. Other system examination is normal.
I will say the precision which you showed in case of history, that precision seems to be have lost in during examination, and this happens simply because you are not ready with your performa. You should be ready with your perform when you go to the intensive phase of preparation. Somewhere on the net you can find when I talk about the preparing how to prepare study during DM exams. So then there is uh, extensive preparation and then intensive preparation. In extensive phase, that is for 2.5 years you do extensive reading, that is can be directed or non-directed reading, and intensive phase is maybe 4 to 6 months before exam. So you case-based preparation, there you for everything you need to have performance. The pain which I was describing, you know what I was talking about performa. So you will have performa that okay pain I'm going to describe in that many headings. Jaundice I will describe that onset, that type, progression, and the present status. So then these errors will not happen. Examination, it was less obvious in case of history, but in the examination it is very very obvious. ठीक है, see, you described nail changes, anything in severe pruritus, what happens to nails?
Shiny.
Are you aware?
Yes, sir. I have. I forgot to write. I have seen, sir. Shiny nails are seen.
Shiny nails. And what are the other changes which can happen?
Blood. Any skin texture?
Subungual hemorrhage. Subungual hemorrhages happen. ठीक है, subungual. Below the nails, there will be hemorrhages. Those will be seen as dark spots. These can be blotches. These can be linear. There can be ridging in the nails. ठीक है, so those changes need to be described. Scratch marks. आपने लिखा है कि सारे स्क्रैच मार्क्स विथ एक्सकोरिएशन एंड ब्लड स्पॉट्स, आर सम ऑफ देम आर इन्फेक्टेड? कहीं पे वो इन्फेक्ट हुआ है कि नहीं हुआ है, वो बताना था ना उसका.
Okay, sir.
एंड गो टू द नेक्स्ट स्लाइड. You say hernial orifices are free, all quadrants next, and you say trophs space, but did you say that spleen is not palpable?
Yes, sir.
Where?
In palpation.
Spleen not palpable. ठीक है. So that's all right. And did you do any? Did you say that ascites is not there? PR. Did you see? Even if you are not doing PR, so then you will say कि I didn't do PR because patient was not very comfortable with the idea, or you will say patient was unwilling. ठीक है. Most of the centers at examination now we provide the PR, or if you ask about the PR, provide the PR findings, or if we don't expect, then we will tell you. But from your side it should come na, बिकॉज मलिग्नेंसीज में अगर पीआर नहीं करेंगे तो दैट इज नॉट एक्सेप्टेबल. एसाइटिस में पीआर नहीं करेंगे तो दैट इज नॉट एक्सेप्टेबल. व्हाई? बिकॉज देयर कैन बी डिपॉजिट्स इन द, सो रेक्टल एग्जामिनेशन यू हैव नो पेरिटोनियल डिपॉजिट्स. पेरिटोनियल डिपॉजिट्स की बात ही नहीं करते वहां पे. हाउ विल यू मेक आउट पेरिटोनियल डिपॉजिट्स? ठीक है. दैट इज नॉट द वर्डिंग और लैंग्वेज विच वी यूज ना.
Yes, sir.
वी प्रीति, वी लॉस्ट योर वीडियो.
You're all. Am I visible now, sir?
नो. So you should be talking about the deposits in the pouch of Douglas. फीमेल पेशेंट है ना, फीमेल पेशेंट है, तो
Yes.
पाउच ऑफ डगलस में डिपॉजिट है कि नहीं, ब्लूमर सेल्फ है कि नहीं.
Too much.
ठीक है. सो दैट शुड बी मेंशन rather than peritoneal deposits. You should be talking about the bloomer self. There will be differential diagnosis for bloomer self. So those are not, you are not seeing peritoneal deposits ना.
Yes, sir.
ठीक है. और ब्लूमर सेल्फ को कैसे डिस्क्राइब करते हैं वो आप प्रिपेयर्ड रहना, क्योंकि एग्जाम में कभी अगर रहेगा तो फिर डिस्क्राइब करना पड़ता है ना. तो दिस इज व्हाट आई एम आस्किंग यू टू मेक प्रोफार्मा इंटेंसिव फेज प्रिपरेशन, दोज थिंग्स. ओके, सो दैट शुड बी डन.
Okay, sir.
But I will, after this examination, I will ask you only one question, that explain the flat abdomen in case in a patient with BMI of 35, 36, sorry, 35 nahi, 36, flat abdomen.
On lying down, her abdomen was flat, sir. It was not protuberant.
Not protuberant. तो या तो आपका BMI गलत है, ठीक है, या तो आपका ये फाइंडिंग गलत है. ठीक है. सो मीनिंग देयर वाई कि आप कोरिलेट, इट इज वेरी इंपॉर्टेंट टू कोरिलेट.
Yes.
And if it is not correlating, then you should be ready with your answer. Okay, otherwise examiner will start questioning your whole thing. So one incredible point that that is not matching and grossly aberrant, then examiner will start suspecting. Obviously with the BMI of 36 we don't expect flat abdomen na.
Yes.
Some degree of protuberant abdomen will be there. Some sort of stria we do expect कि some will be some stria. Stria था कि नहीं था?
No. No stress, sir.
फीमेल पेशेंट है ना?
Yes, sir. But. अच्छा.
बच्चे हैं कि नहीं इसके?
है सर, बच्चे हैं.
है ना?
है सर.
फिर कुछ नहीं तो व्हाइट स्ट्राया तो होगा ही होगा. ठीक है. तो वो भी नहीं डिस्क्राइब किया. ठीक है. जब स्ट्राया देखेंगे तब देन वी विल टॉक अबाउट द पिंक स्ट्राया एंड व्हाइट स्ट्राया. ठीक है. सो वो सारा क्रेडिबिलिटी लॉस हुआ. यहाँ पे तो ऑनलाइन है, वी आई कैन नॉट चेक. बट अगर ऑफलाइन रहेंगे वहाँ पे जब नेशनल बोर्ड एग्जाम में ना, तो वहाँ तो मैं ले जाऊंगा पेशेंट के पास में. ठीक है. एंड देन द स्टोरी विल अनफोल्ड कि फ्लैट एब्डोमेन है कि प्रोट्यूबरेंट एब्डोमेन है. ठीक है. सो दैट बिकम्स, माने For the patient management, that is not relevant, but that is highly relevant for your credibility. Okay.
Okay, sir.
So after examination, what are the possibilities?
So final diagnosis will be cholestatic jaundice.
Not final diagnosis.
Sir.
Clinical diagnosis after examination. Final diagnosis will be after
After
investigation.
clinical diagnosis. Okay, sir. Okay, sir.
हाँ,
Uh,
so final clinical diagnosis अगर बोलना है तो.
Probably it could be carcinoma gallbladder, sir.
So carcinoma gallbladder. So you want to keep one possibility and rest you want to remove.
Yes, sir.
Why so? You have to justify.
Yes, sir. So gallbladder is palpable and intrinsic mobility is absent, sir. Sir,
Okay.
it's absent, so I would consider carcinoma arising from gallbladder, carcinoma gallbladder.
And whenever we manage anything, then जीआई ब्लीड आप मैनेज कर रहे हो, मैलिग्नेंसी मैनेज कर रहे हो, आप इसमें ईआरसीपी कर रहे हो, इसमें आप यूएस गाइडेड ड्रेनेज कर रहे हो, द आउटकम विल बी डिटरमिन्ड बाय द पेशेंट्स कोमॉर्बिडिटी. ठीक है. हाइपरटेंशन की डायग्नोसिस कहाँ गई इसमें?
Comorbidities में है, sir.
कोमॉर्बिडिटीज में. और ओबेसिटी की कहाँ गई?
Yes, sir.
ओबेसिटी है?
Yes, sir.
नहीं
Obesity.
है ना. So that is also very important determinant. So you will know. And in this era, in Western world, you know that what is the commonest region of HCC now in Western world?
Na,
हाँ.
MASH,
So
metabolic.
related cirrhosis and HCC. तो
Yes, sir.
HCC आपने consider तो किया था ना. तो based on what findings we have removed HCC now?
Pruritus
नहीं,
initially.
वो तो हिस्ट्री थी ना. हिस्ट्री के बाद तो आपने उसको लिवरेज दे ही दिया
Gallbladder is
था.
palpable now, which is globular mass.
तो ग्लोबुलर दैट इज एक्सोफिटिक hepatic mass.
It is firm in consistency, sir.
So
The
that will
mo-
be firm only. अगर कार्सिनोमा गॉल ब्लैडर फर्म हो सकता है तो वो भी फर्म हो सकता है, वो भी malignancy है. You understand what I'm saying?
yes, sir.
Probably you are not. So
And
when you you are probably you are not understanding. Let me speak. So when you make changes after history, after examination, then the changes will be made strictly according to the physical findings. So if you are adding something or you are removing something, then you should be ready to answer that based on what findings you have removed that. So because you are describing a mass lesion in gallbladder fossa, so that will be the GB mass, and the second differential diagnosis will be liver nodule deposits, for which we know the differential diagnosis. It can be metastatic nodule. And the third point, which I have discussed, should have discussed earlier, the how do you explain sharp margin?
sharp margin of liver.
Yes, ma'am.
Extrahepatic biliary obstruction, there will be sharp margin, sir.
No, there will be rounded margin. So you need to understand and learn in the palpation that how to make distinction between the sharp margin and the rounded margin. So virtually all cholestasis, all venous congestion like Budd-Chiari syndrome, the margin will be rounded only. ठीक है. So you should not describe as a sharp margin because you are feeling, because it has become firm, abdominal wall tone is less, and you are very feeling very clearly. That doesn't make it sharp margin. ठीक है. So you need to revise on that.
Okay, sir.
So okay. At this stage, you will be asked two types of questions. So you should be ready in your mind that how are you going to answer. You will be asked either how will you confirm the diagnosis or how will you investigate this patient. The approach will be completely different. So when you are asked that how will you confirm the diagnosis, then only diagnostic investigation we mention. And when we ask how will you proceed, then you have to go stepwise. Okay, so here I'm asking you, how will you proceed with in investigating this patient?
First, I'll ask for blood investigation, sir. CBP to look for anemia since she's having loss of appetite to look her hemoglobin status, and since she's elderly also, she may not mount had fever, but I still want to look for any leukocytosis to rule out subclinical cholangitis.
What is the commonest manifestation of cholangitis? टोक्यो गाइडलाइन में जो एसोसिएटेड लिटरेचर है उसमें क्या बोला है उन्होंने?
Fever is present in 90% of the patients.
Symptom wise fever is the commonest, but
Commonest.
overall manifestation में which is the most relevant?
Abdominal pain and jaundice.
फीवर तो कॉमनेस्ट हो गया, तो एब्डोमिनल पेन तो ऑब्वियसली उससे नीचे है. सो ल्यूकोसाइटोसिस. सो इन्वेस्टिगेशन में बात कर रहे हैं ना, तो ल्यूकोसाइटोसिस. तो
Leukocytosis.
फीवर तो है नहीं इसको, तो देयर इज नो कोलेंजाइटिस क्लिनिकली, बट इन्वेस्टिगेशन में इफ देयर इज कोलेंजाइटिस और नो कोलेंजाइटिस, दैट विल बी decided by leukocytosis, whether there is leukocytosis or no leukocytosis. Okay,
Okay.
so somebody is there to show the investigation, or you have access?
Yes, sir. I have in my. I didn't see report, sir, but I have this in my same PPT.
Huh?
I'll show, sir, but I didn't see the reports earlier, like right current.
So if you have
I'll share. Yes.
so you can share.
Yes.
So okay, hemoglobin is preserved, and creatinine is high, and potassium is low,
No.
and INR is deranged. ठीक है? And
Yes.
then bilirubin 27, OTPT 4170,
Police
ALP.
obstruct.
ALP, what is the normal value at your center?
120, sir.
120.
Yes.
So this is fourfold elevated.
Yes, sir.
Okay, albumin low. पिफ का क्यों हुआ था इसका? एफपी
Schindler.
एफपी 1960 है, तो पिफ का क्यों हुआ था इसका? तो साइमल्टेनियसली वी ऑर्डर इन बंडल. ये 19-9 3380. So interpret all this result.
So it is obstructive cholestatic jaundice, sir, with direct hydrogen and all tumor markers are raised as CA 199.
So it is going in favor of uh, they say more than threefold. At some of the places it is said more than fivefold is typical of malignant obstructive jaundice. Okay.
Okay, sir.
And then bilirubin very high, more than 18 they say is typical for
No.
malignant biliary obstruction. So softly, but it is going in favor of malignant biliary obstruction, and albumin 2.9 is low. So we need to see that how much there is underlying chronic liver disease. Okay, because she can be having underlying chronic liver disease, and then she has developed superadded malignancy, because hemoglobin is preserved, and then we don't expect 2.9 of albumin.
Okay,
And
sir.
then if PIVKA both are high, so we said. So this is exactly the point I was discussing after examination when you removed SCC as a diagnosis, that based on the findings you cannot remove SCC from there.
Okay,
Okay,
sir.
that will remain low on the card, but
Okay.
that will remain there because historically we have considered. So then after examination also, then go further investigation. You will go for MRCP or you will go for something else?
Ultrasound abdomen, sir.
Ultrasound abdomen. So obviously step-wise investigation, you will do ultrasound first. ठीक है? So why ultrasound is important?
To look for IHBG to confirm extrahepatic biliary obstruction
So
and
very
also
important. So ultrasound can show evidence of biliary obstruction, and also ultrasound can show etiology of biliary obstruction.
Obstruction.
So first of all, because here the confusion has arisen because the SCC markers are positive. So we want to see whether there is extrahepatic biliary obstruction or not. For that matter, ultrasound will be highly relevant. So go ahead with MRCP if you have MRCP, no problem. Large gallbladder mass infiltrating this thing, duodenal cap, and near cutoff of primary biliary confluence. So we have GV mass and we have biliary obstruction. ठीक है, and multiple liver mets, majority showing rim arterial phase enhancement and progressive centripetal similar to that of the large primary gallbladder mass. One of the lesions in segmental arterial phase hyper enhancement with washout. So, and mild ascites. This is what I was talking about. Peer examination, you should be very meticulously, you should see for the bloomer cell. Are suggestive of primary carcinoma gallbladder with multiple liver metastasis. Okay, fine. So, next, what are you going to do?
Uh, to, so I would like to take biopsy from liver lesions, sir. Here.
Biopsy क्यों चाहिए?
So we are not sure whether it is metastasis or primary hepatocellular carcinoma.
Okay, so which you will take from GV mass or you will take from the liver swab?
Liver as well, sir, if it is feasible.
Feasible, why not? It will be easier to take from the liver swab compared to the GV. Na?
Yes, sir.
So if you have multiple sites, like this patient has pancreatic mass and then this patient also has liver swab, then which site you will sample?
Then also liver. Liver I'll take, sir.
Why?
It confirms it is metastatic.
If the rule of thumb is the site which gives you highest stage of the disease, you will target that size. ठीक है, so imagine the situation, this patient also has pancreatic mass, liver swell and supraclavicular lymph node, then obviously you will target the supraclavicular lymph node. Okay,
Okay.
so the whichever site you get. Similarly, gallbladder, if we target, we will prove only malignancy. ठीक है, but if we target liver swell, we will prove malignancy as well as we will
Stage.
prove the metastasis into the liver. So that is important from the practical management point of view. So in malignancy, here another question, it could have been FNAC and you said biopsy. Why biopsy? Why not FNAC only?
To look for IHC markers.
Very good answer. ठीक है, so earlier it used to be always FNAC, but because now immunotherapy is widely available, widely used, so that require immunohistochemistry and certain markers. What are those markers? Some of the markers, you know,
In
in carcinoma gallbladder or hepatobiliary malignancies.
cytokeratin 7 and
No, cytokeratin is not, you don't have anything directed against cytokeratin for immunotherapy. For immunotherapy, you have certain agents which are directed, and then you require marker like.
it's
So you should be ready with that answer.
okay, sir.
Okay, so you need to prepare.
Okay, sir.
So PDL1, have you heard?
Yes, sir. Yes.
हाँ, so PD1 उसके against में
Then,
available है ना.
period.
So that's why we nowadays it is always biopsy rather than FNSC. Okay, so some sort of biopsy or cell block we require. ठीक है, so this patient will require palliation of jaundice for two. What are the indications of palliation of jaundice?
So cholangitis, sir.
Cholangitis, very good.
And if you are considering like this patient, she has to undergo chemotherapy, palliative chemotherapy. So before starting chemotherapy, I would like to bring like do biliary decompression and bring down her bilirubin to less than 5.
Or or what is the other indication?
Severe pruritus also.
Severe, no, don't change the word. The word is not severe pruritus, intractable pruritus.
Intractable pruritus.
There is difference because pruritus can be severe, and if it responds to medical therapy, then it will not be indication for drainage. If medical therapy is taking care, okay. But if it is not responding, then it will be intractable. So intractable pruritus. So
Okay.
what is the difference in drainage strategy when you are doing for cholangitis versus other indication? Same strategy or there is different strategy?
Sir, different.
You you understand because this is hilar block, na?
Yes, sir. Huh. Strategies.
Okay. So this say for this is type 2 block.
Mm.
So
Yes.
the question will arise whether you are going to do right duct stenting, left duct stenting, bilateral stenting. So you are going to do partial drainage or you are going to do complete drainage.
I would aim to do complete drainage, sir. If not possible, at least I'll drain at 50% of the. I'll put a stent where 50% of the liver is decompressed.
Common sense is good. Most of the time it helps, but doesn't always. So because I was, it was a leading question in a way because the strategy differs depending on the indication. Okay, for cholangitis, total drainage. So if you leave any segment undrained, the infection will persist and ultimately flare up. Okay, so for cholangitis, there is no. So the answer was itself leading to answer that in one situation it will be complete drainage, and in other situation it will be even partial drainage will be good enough. So how much partial drainage? It is not 50%, it is 60%.
60%. Okay, sir.
Okay. And how do you decide 56? How do you are achieve 60% or not?
I IHBRD.
There was disturbance I didn't hear. So how do you decide it is 60% drainage?
So usually right lobe, 60% of the drainage will be achieved, sir. Even if you.
So that is very important. That if you are draining right main duct, so you are draining 60%. So that should be good enough. So there is no compulsion. If you are easily able to access left, then you will go. Otherwise, right should be good enough. Okay. But if you are gaining excess of left duct, it will be mandatory to drain at least part of the right duct because that will be 40% or less. Okay. So that is the difference in strategy. Now comes whether you will go for metal stent or plastic stent.
Since it is inoperable, I'll go with metal stent, sir. And it is metastasized to liver also. Her lifespan, overall lifespan is less than 6 months. So I would consider metal stent.
So less than 3 months में metal stent and more than 3 months में plastic stent.
Less than 3 months plastic stent, sir. Less.
Less than three. But you said here metal stent.
6 months, I told.
So because we are going to give chemotherapy, so that situation the metal stent. Okay. So because longevity will be prolonged. Otherwise, projected untreated longevity for this patient is less than 3 months. So here it could be either plastic stent or metal stent. It doesn't really matter. So if you use plastic stent, you will use which type of stent?
Double
DPT stent, straight stent, 7 French, 10 French, 11.5 French, which stent?
double pigtail stent I will use, sir.
Double pigtail. Why so double pigtail?
Chance of migration is less.
नो, माइग्रेशन के लिए तो फ्लैप्स होती है ना, जो स्ट्रेट स्टैंड्स में फ्लैप्स होते हैं, ठीक है? स्ट्रेट स्टैंड्स हैव a better long-term patency compared to pigtail stents. So stricture situation, in this situation, there will be straight stent, not the pigtail stent. And which French? 7 French, 8.5, 10, 11.5.
10, 10 French, I
Why
guess.
not 11? Why not 11.5? Your scope diameter is how much? Scope channel diameter is how much? And scope diameter is how much?
11.5 to 12.6 is our scope diameter, sir. And working channel is
And channel diameter?
4.2.
4.2. So the largest stent we can place is 11.5 centimeter.
Okay, sir.
11.5 French. So
French.
you can pick up 5 French, 7 French, 8.5 French, 10 French, or 11.5 French plastic stent. So which one you will pick up? Simple question. Uh,
11.5
long
French.
term patency किसकी better होएगी long term patency?
Higher the French, longer the higher the pattern. Long,
हाँ, generally speaking कि wider diameter more patency,
more patency.
but there is no difference between 10 and 11.5. Okay, so that's why you must have not have seen many times 11.5 being put. It is always 10. So 10 is superior to 7, but 11.5 is not superior to 10. So that's why we go for 10.